I welcome you to another session and another lecture, another topic. And for today, we'll be discussing about your respiratory problems. Okay, so in this topic, we'll be learning about how important your respiratory system is, why does it exist, what does it do, and how connected it is to other systems, the basic diagnostic tests, and of course, your special nursing considerations in every disease process, and of course, pharmacology, and also the disease process itself. Okay, so welcome to respiratory problems. So when we say respiratory problems, ang dalawang bagay po na pinakamalaga that we should be thinking about is that it performs two functions, kapatid. So what are those two functions? So kapag sinabi natin respiratory, we immediately think of two major gases in our body. What are those? First, oxygen. I know that you know this one. So your respiratory system actually provides oxygen for metabolism. It is the circulatory system, yes, that circulates the blood which carries oxygen all throughout our body, but without respiratory system, that oxygen in our body will not be absorbed in the first place. So it is the respiratory system, kapatid, that provides and actually lets the oxygen enter into our body through the alveoli, and we'll be discussing that later on. And upon the other hand, there is this gas sa katawan natin, kapatid, na kailangang lumabas. And we call that as your carbon dioxide. Okay, so carbon dioxide is a waste of the body, and oxygen, that's the type of gas, type of substance that we need in our body for metabolism. Okay, so what does our respiratory system do is that it lets our oxygen enter the body, and it also excretes carbon dioxide upon the other hand, because our body doesn't need it anymore. Okay, so your carbon dioxide will perform a very, very crucial part in your anatomy and physiology, and we're gonna discuss that later on upon this discussion. Okay, so now, aside from the oxygen and carbon dioxide relationship and the process that we do with these two gases, kapatid, our respiratory system also performs other functions. Say, for example, sense of smell, maintenance of acid balance, maintenance of body water levels, because as we all know, kapatid, that your lungs is also responsible for this, what we call as your insensible fluid loss. So when we say fluid loss, we immediately think of kidney, but um, we actually must remember that our lungs is also very important in elimination or excretion of our fluid in the body. That's why kapag humihinga po tayo sa isang, halimbawa sa glass, makikita po natin na there's a moist. It's because it's fluid loss. It's what we call as your insensible fluid loss. And aside from that, it also maintains heat balance. Okay? So now in we've mentioned later on, when we've mentioned earlier that we have these two gases, very important gases that we have in our body. We have the carbon dioxide, we have the oxygen, and they are involved actually in one single process, and we call that as your gas exchange. So gas exchange is the delivery of oxygen from the lungs to the bloodstream, and the elimination of carbon dioxide from the bloodstream to the lungs. So papasok po yung oxygen sa katawan natin because it's the gas that we need, and lalabas naman po yung carbon dioxide from the bloodstream to the lungs. And in a specific part of the lung, okay, in a structure which we call as your alveoli, a passive diffusion occurs, and that's what we call as your gas exchange. It's where your gas exchange occurs. Okay, so again, it's in the alveoli of the lungs, which performs like really a balloon. Okay, these are tiny structures in your lungs wherein passive diffusion occurs. It is where exchange of oxygen and carbon dioxide occurs. Okay, so basic terminologies that you need to remember. First is ventilation. Kapag sinabi natin ventilation, this is the process of air movement in and out of the lungs. Okay, while oxygenation is the presence of oxygen in the bloodstream, from the word itself. Self-explanatory, presence of oxygen in the bloodstream. While perfusion is the distribution of oxygen in the tissues. So perfusion is actually the process of distribution of the oxygen all throughout our body, in the cells up to the tissues. Okay, now without proper ventilation, without proper oxygenation, your perfusion wouldn't be successful. So that's why we need to have a proper ventilation. So going back to the problem, going back to the concept of your gas exchange. So gas exchange is a very important process. So without this proper gas exchange, there would be no proper ventilation. So there would be no oxygenation. There would be no perfusion. So just imagine in some problems wherein there is a disruption in the normal function of your alveoli. What will happen now to your oxygenation all throughout the body? So it would also be disrupted. Okay, so now aside from all of those basic concept and terminologies, kapatid, suking-suki din sa boards itong ating mga breath sounds. Okay, so when we say breath sounds, we have two types. We have your normal breath sounds and we also have your abnormal breath sounds. Kapag sinabi nating abnormal breath sounds, that's otherwise known as your adventitious breath sounds. Okay? So, let's talk about your normal breath sounds. Kapag sinabi nating normal breath sounds, these are your tracheal breath sound, bronchial breath sound, bronchovesicular, and vesicular breath sound. Okay? So, four major normal breath sounds. Again, we call that tracheal, bronchial, bronchovesicular, and vesicular. Upon the other hand, we also have these abnormal breath sounds, again otherwise known as your adventitious breath sounds. And I have listed here four of the most common adventitious breath sounds. We have crackles, rhonchi, the very famous wheeze or whizzing, and of course stridor. Okay? So what does our breath sounds tell us? It's telling us that there's maybe there's abnormality in our airways. So ito po ang nagsasabi, kapatid, na kung saan may naka-block sa ating airways. It can tell us something. If it's normal breath sound, then it's normal, and if it's adventitious breath sound, so there's currently occurrence of something that's beyond normal within our airways, within the lung, okay, within the lung field. So it's telling us something. So now let's talk about your breath sounds and how can we hear them. Okay, so for your for your normal breath sounds, basic na tinatanong, kapatid, sa PNLE, even in the NCLEX, kung saan po sila na-assess. Okay, so for your tracheal, big word in a board exam, over the trachea, tracheal, trachea. Okay, while in your bronchial breath sounds, bronchial, okay, can be assessed in the upper anterior chest. Okay, again, upper anterior chest. While for your bronchovesicular, okay, it can be assessed anteriorly or posteriorly. So it can be assessed posterior chest, okay, between the scapula or the center of the anterior chest. So look at those green dots, those green marks in the chest and in the back, and you can see where can we assess these normal breath sounds. And lastly, for your for your vesicular breath sounds, it is actually assessed in most of your lung fields. Okay, so now let's discuss about your adventitious breath sounds. So when we say adventitious breath sounds, again, they are your abnormal breath sounds. So I have listed again four commonly asked adventitious breath sounds in your exam. So first, we have crackles. So when we say crackles, that's actually popping. Okay, it's like nakikinig po tayo sa bonfire na kung saan may popping pong nagaganap, no, when the wood is now being burned. So what are the causes of your crackles? Air movement through mucus, fluid accumulation. How about your rhonchi? So kapag sinabi natin rhonchi, kapatid, this is actually the snoring, low pitch. These are the common terms na lumalabas in the boards, and it can be caused by your large airway secretions. So if there are secretions in their large airway, so there will be snoring, okay? So it means that there's something in your airways, and those are large airway secretions, and that's what we call as your rhonchi. Another thing is we have your wheezes. So when we say wheezes, kapatid, this is musical, high pitch, and more heard in your expiration. So this is expiratory high pitch, which is musical in nature. So this is actually caused by your shallow restricted breathing, just like in the case of your asthma. So wheezing is actually the superstar among the adventitious breath sounds. Okay, so another breath sound in your abnormal list is your stridor. Kapag sinabi namin nating stridor, kapatid, this is your high pitch. Ang pagkakaiba nila, I mean, pareho sila ni wheezing, they are high pitch, they are musical sound. Ang pagkakaiba nila is that your stridor is more on the inspiration, in the inhalation. Okay? So what does stridor tell us? It tells us that there is an upper airway blockage or there is an upper airway obstruction. Okay? So these are our adventitious or abnormal breath sounds. So now, another thing that we need to be equipped with is the concept of your oxygen therapy. What does oxygen do? What are the attributes of your oxygen? Okay? So first, what you need to remember is that your oxygen is a dry gas. So that having it as a dry gas, you need to humidify it. That is the purpose actually why we have this chamber here wherein we need po your sterile water, yan, distilled water, and we need also a lubricant which is water-based lubricant. Okay? So if you will be asked what is the color, this was once asked before, no? What's the color of your oxygen? Many have answered green, but in reality, the answer is that it's colorless. It has no color. It's transparent. Okay, so colorless, and it is also odorless. So when it is odorless, it means it is very very prone to leakage. Okay, because you cannot just say na nagli-leak yung oxygen. Okay, kasi naaamoy mo. No, it's actually odorless. And aside from that, kapatid, it's also highly combustible. That's why we must place a no smoking sign. Okay, this is for the safety of our patient. We should also avoid silk. Okay, avoid silk fabrics and avoid also sparks. So we must place a no smoking sign. We must place the cylinder, the oxygen cylinder, apart from a electrical plug. That's why we should avoid sparks. And also again, we need to remember that if you will be asked about the tank color, it's actually green. Now let's talk about your oxygen masks. So we have here three. First, we have your nasal cannula. Nasal cannula is actually the most commonly used type of oxygen delivering device. So it gives us actually 24 to 40% of oxygen. Okay, so most common nasal cannula. While your simple face mask, it is actually giving us a bit higher, so 35 to 55% of oxygen. So this is given for those who have problems with their nostrils, so or depending upon the order of the attending physician. And for your non-rebreather mask, this actually gives you 100%. Why always put that to 100%, though it gives you 96 to 100, 98 to 100, or as much as 98%, because I want to make you realize that whenever you will be asked of that of the highest, no, you will be thinking of only one, and that's what we call as your non-rebreather mask. So you see that valve. Okay, can you see this valve which is not found in your simple face mask down here? Because kapatid, it's where your patient directly breathe oxygen or inhales oxygen. So it's full of oxygen. That's why it gives you 100%. And this tubing here is a one-way tubing. Okay? So ang lalabas po within the mask because it has an para siyang may pores dyan. So ang lalabas dyan, kapatid, is your carbon dioxide. Upon the other hand, ang papasok ay walang iba kundi oxygen lamang. Okay? So we call it non-rebreather mask. Okay? So these are low flow masks and these are your high flow masks. So when we say high flow masks, we have two. We have your Venturi mask, okay, and we have your high flow nasal cannula. So your Venturi mask can actually give you your 25 to 50% oxygenation, and of course it has ports, and that's the distinction that we have for your Venturi mask. And on the other hand, we have your high flow nasal cannula, which can provide you up to 40 to 60 liter per minute. So this is really a high flow um, oxygen device. Okay? So another concept, kapatid, is your endotracheal tube. So endotracheal tube is an invasive artificial airway for patients who are unable to breathe normally. Okay? So it's like the famous thing that we have in the country, we call it intubation. So you don't need to become masters in your intubation because we will not be doing this. But what you need to know is why is this given to your patient. So it's an invasive artificial airway for patients who are unable to breathe normally. Because they cannot breathe normally through their normal breathing pattern, we need to put them in intubation. Okay? So now, once the doctor or once the physician, usually the anesthesiologist, okay? So, depende yan sa practice po natin in the country. So, whenever the nurse, the doctor have already inserted the endotracheal tube. So, how can we verify? So, big word, verification is done through X-ray. The same as well with your nasogastric tube. Okay, the verification or the mode to verify is through the X-ray. Now, ang tanong sir, kung paano yun kapag walang X-ray and malayo, no? So, how can we know that the tube has actually proceeded to your respiratory system, because it can be dislodged to your GI? So, the answer is very simple. If no X-ray, assess for bilaterally equal breath sounds. Okay? So, again, if no X-ray, you should assess for your normal breath sounds. Equal breath sounds. And you need to remember that your ET tube or your intubation, okay, is used for short-term or short-term duration and in your critical cases only. Okay? So, you need to remember that one. Now, another thing is your tracheostomy tube. Because your patient can't be in endotracheal tube forever or for a longer time, we need your trach tube. So we call this trach tube. So tracheostomy tube is actually an artificial airway used for long-term needs. So short-term for your endo during hospitalization, while your trach is an artificial airway used for your long-term needs. So it is where a stoma here, okay, it's where a stoma, that's why we call it ostomy. There's a surgical incision. Okay, so we've made here an ostomy. Yan, stoma, and we call it stoma. Is made in the neck and the tube is inserted. Okay? So, it is here in this tube wherein breathing is made. So, dito na po ang breathing, ang normal breathing ni patient. So, this is done for those patients who cannot anymore breathe through the normal breathing pattern. Also, lalo-lalo na yung may mga neurological defects, no, having a problem in your naso, and also problems in your mouth. So, breathing is made through this stoma, kapatid. So, now in your tracheostoma care, in your trach care, and big word always in the board examination, priority is avoidance of infection. So, infection, you always think that your patient might get an infection out from your yucky trach tube. Okay? So, position. How do you position the patient here? Fowler's or low Fowler's position. Okay? So, also clean the site using normal saline and hydrogen peroxide. So, 1 part and 1 part. So, 1:1 ratio. And you need to prepare 2 extra tracheostomy tubes at the bedside of the patient. So, in case this tubing will be dislodged, at least you have 2 extra trach tubes there. Okay? Okay, let's talk about your chest tube therapy. Favorite also in the PNLE. So, chest tube therapy is actually, it is where we use tube inserted into the pleural space of the lungs. So, it's where we use actually this in cases of your example in your pneumothorax, in your pleural effusion, in your patients with abscess, lung cancer, hemothorax. Okay, so inserted to remove air or fluid from the lungs. So ang problema po natin kapatid is that kung example here in these illustrations here, so in case of stab wound, say for example, or trauma, so your lungs would actually collapse and your fluid would easily accumulate on the pleural spaces. So now, to avoid that to happen, we need a CTT or your chest tube therapy. So this is indicated in cases like your stab wounds, pleural effusion, card, cardiac operation or cardiac surgery, or even in your lung surgery. So, if we will not remove this fluid here, kapatid, tutulakin nito yung ating lungs, no? Hence, that's what we call as your tension pneumothorax. So, there would be an increased tension pushing your lungs, and then your lungs would collapse, and that's what we call as your atelectasis, and the event or the situation is we call as your tension pneumothorax. Okay, so it could happen here wherein blood is pushing, and it could also happen here maybe due to an infection wherein pus or your accumulated fluid is pushing your lungs. Okay, so that's what we call as your chest tube therapy. So big word in the board examination, your chest tube, your CTT has is what we call as your drainage system. Okay, basically it has three basic drainage system chambers, and we call these chambers, which are suction chamber, water cell chamber, drainage collection chamber. So when we say suction chamber, kapatid, it's basically where the fluid suction from the patient goes to. Okay? So what do we want in your suction chamber? We only want that word gentle bubbling. Yun lang yung kailangan natin dito. And also, there should be no tidalling. Okay? No tidalling din dyan. What we need there is gentle bubbling. Again, close your eyes and then you memorize suction chamber. We don't need here tidalling. What we only need is your gentle bubbling. Okay. Another chamber is the one in the middle. We call it water seal chamber. We see here water. Okay? So, now in this chamber, it's actually we will see this intermittent bubbling. Okay? Intermittent bubbling. And big word, we have that tidalling. Yan. So, tidalling, makikita po natin yan dyan. While in your drainage collection chamber, kapatid, it's basically where your drainage goes, and this is where your patient is connected to. So it's where your drainage collection will go. So here, no tidalling also. What we have here is your drainage. It can be pus, it can be your fluid, it can be blood. So ang normal color dito po ay normally it should be pinkish in nature. Okay? So again, tidalling only happens in your water cell chamber. And what do we want to know about your tidalling? Okay, so kapag sinabi po natin tidalling, this is the up and down movement of the water in the water cell chamber. So it's gonna up and down in your water cell chamber. And what does it mean if it rises? If it rises, kapatid, okay, so that is the inspiration of the patients, where you inhale, and when it falls, kapatid, this is where your patient exhales. Okay, so that's during your exhalation or your expiration. So what does it mean when there is no tidalling in your water seal chamber? So absence of tidalling in your water seal chamber actually could be meaning two things. Okay, first, it could mean obstruction in the tube. So you now know, kapag may nag-stop yung tidalling, if you assessed, and if you will be asked in the PNLE, you saw or you assessed that the tidalling in the water seal chamber stops. So what is your first nursing action, or what does it mean, or what does it tells you? Okay, so it could actually tell you that there's an obstruction, and also it could mean that your lungs has fully expanded. So kapatid, tandaan po natin yan. Okay? So, when there's no tidling again, it could mean two things. It could be meaning as um, that there's an obstruction, which is a negative thing, and positive thing upon the other hand is that it could mean that your lungs has already expanded. Okay, so what are your nursing considerations here? What you need to know is that first, to keep the drainage system below the client's chest at all times, kapatid. Kailangan natin yan. Okay, check for kinks of the tubing, monitor drainage, and monitor for disconnections. So, when we say disconnection, it is where your your nurses, your student nurses, quite confused. So, dalawa po ang disconnections na pwedeng mangyari. First is, pag matanggal sa client's chest, what should you do? Pangalawa, pag matanggal naman sa tubing or just doon sa chamber, what would you do? Okay, so if matanggal po mula sa chest, what shall we do is that we will cover, okay, the insertion site with sterile dressing, then tape on the three sides. Sir, bakit three sides lang? Bakit hindi natin gawing four? Kasi square naman po usually, di ba? So, we will be taping the three side simply to avoid or to make a vent and to avoid this what we call as retention pneumothorax. Okay? And immediately call the physician. How about if the tubing has been disconnected from the chambers? So kapag sa chamber naman po siya natanggal, gently place the end of the tubing on a bottle of sterile water. Okay? So this is the thing that we need to consider, we need to remember. It's again where our students quite confused because hindi nila alam in the first place what does it mean kapag may matanggal po na tubing no sa patient's in the patient's CTT. Okay. So now, let's talk about your respiratory pharmacology. Three basic pharmacology that we need to know here, generally. Okay, we have your bronchodilators, your steroids, and your antihistamines. Okay, so for your bronchodilators, commonly used are your albuterol, salbutamol, ipratropium, terbutaline. We sometimes use your theophylline, okay, but that's for your usually long-term cases because it's a slow-acting bronchodilator. Or aminophylline, those are the things. Okay, so another thing is your steroids. So for the steroids, what we usually use, dexamethasone, hydrocortisone, betamethasone. And of course, your antihistamines as well. Most commonly used, your diphenhydramine. And we know this thing. Monitor for drowsiness, avoid driving. So those are the special consideration that we have for your antihistamines. Okay? So now, bronchodilators. So considerations that we need and commonly asked in the board exam, we should be cautious for patients with heart disease, diabetes, glaucoma, and seizures. Why? Because they act in your adrenergic receptors. Okay? So it can also cause your tachycardia, and that's why we must check pulse before administering. So para pa sa mga pasyente na nagtatachycardia, always be careful when you're giving with your bronchodilators. And take note if it will be asked in the boards or your examination at school, you take note of this one. Check the pulse before administering or before starting your nebulization with your bronchodilators. Okay, so another thing are your steroids. Consideration, we know this, kapag steroids, immunosuppression. Okay, also hyperglycemia, because again, that's corticosteroids, and also water retention. So, for those patients, kapatid, na may mga CHF, for those patients na mayroon pong SIAD, yan. So, always be careful with your steroids or any condition that retains more and more water. So, we don't want to retain more and more water here because you're gonna add up to the burden of the patient. So, be very careful. Next are your antihistamines. So, what you need to know with your antihistamines, we need to monitor for drowsiness, and we also need to do an oral care. Why? Because it can increase your salivation. Okay? So remember these things here. Okay, so now let's discuss about your problems. First in the list is your asthma. Okay, so kapag sinabi natin asthma, kapatid, this is otherwise known as your airway hyperresponsiveness. Okay, it is marked by chronic spasms and inflammation in the bronchi and bronchioles, and attacks of your asthma, or we call it asthma attacks, usually occurs because of allergic reaction or hypersensitivity, and we call that triggers. Yan. Okay? So, asthma, one of the most commonly asked in the board examination, kapatid. So, we must be very, very familiar with this concept here. Okay. So, now, again, attacks are usually due to allergic reaction or hypersensitivity to these things which we call as your triggers. Okay, so asthma happens again because of those triggers. So what happens is there would be this hyperreactive airway, and that reaction, kapatid, magkakaroon inflammation and decreased mucus. So it will lead you to having this narrow airway, and that's a problem. Priority always in the medical surgical nursing is your airway. Big word in the board examination. Okay. So, what are the triggers of asthma? Kapatid, remember asthma also. First, we have your allergens. All of those pollen grains, all of those during springtime, we have your leaves. Yan. So, you must be very careful with those. Halimbawa, si patient, no, she's taking care of the garden, she's taking care of the lawn, she's taking care of, he or she is a grass cutter and is also a known asthmatic. So those are the hints. Allergens. Okay. Smoking. Smoking. That's a cause also or trigger of asthma. Sports. Stress. Okay. Temperature change. Say for example, extremely hot temperature, so extremely cold temperature, so it can also be a trigger of your asthma. Hazards, microorganisms, anxiety. Okay, so these are triggers to your asthma. Okay, so how do we assess, or what are those assessments that we can see possibly in our patient? First is your shortness of breath, cough, because um, we want to expel this something within the airway. Okay, increased work of breathing, wheezing, a very classical sign of your asthma. Absence of breath sounds, kapatid. And we need to remember that in your breath sounds, that's why it's very essential for us to assess the breath sounds in your asthma. It's because absence of breath sounds is actually an emergency. It's where our patient is unable to speak. It's where our patient is unable to verbalize that he or she is actually having difficulty breathing. Okay? So absence of breath sounds is an emergency. So this is the total blockage of your airway. So we need to respond to this immediately. Okay? So next is your prolonged expiration. So basically your asthma, we have a big problem here with your airways. Okay, how do we treat your asthma? We also treat it with your asthma. Adrenergic agonists. So albuterol is an example. Steroids, theophylline, hydration through IV fluid, mask for oxygen delivery, and anticholinergics such as, say, for example, your ipratropium. And for this ipratropium, commonly in the Philippines, kapatid, we have this salbutamol plus ipratropium. So it's a combination of your adrenergic agonists and also your anticholinergics. So they are also they're already combinations. So brand name for that most famous is your Combivent. Okay. So next, what's the biggest complication of your asthma? So biggest complication of asthma is what we call as your status asthmaticus. So this is more severe type of your asthma. So always respond very quickly. So first to respond to is you need to open your airway. Okay, before giving your oxygen, open first your airway because airway is always the priority in asthma. Airway, breathing, and then circulation. So status asthmaticus, if left untreated, can lead to death. Remember that one. Okay, so what are your long-term treatment regimen for your asthma? So we have your inhaled corticosteroids, leukotriene modifiers, theophylline, I've said that earlier, and also allergen control. Also stress control perhaps. So lesser stress, okay, lesser tendency to have your asthma attacks. Okay, so another problem is your chronic obstructive pulmonary disease. So kapag sinabi natin chronic obstructive pulmonary disease, this is your COPD, and it's a group of diseases in the lungs due to airflow blockage and breathing difficulty. So it includes emphysema, chronic bronchitis, and also asthma, because some actually exclude asthma here. Kung ang asthma ba, is it a chronic obstructive pulmonary disease? Yes. Is asthma chronic? Yes. Is asthma obstructive? Yes. Is it pulmonary disease? The answer is yes. So it's actually chronic obstructive pulmonary disease in the first place. And it also causes irreversible damage. So damage in your COPD is irreversible. Remember that one. Okay. So again, three combinations of your diseases here. We have your emphysema, which is the alveolar destruction and inflammation causing poor gas exchange. This is otherwise known as your pink puffer. Chronic bronchitis, okay? So this is bronchial inflammation characterized by productive cough. So emphysema, alveolar destruction, chronic bronchitis, bronchial inflammation characterized by your productive cough. Okay, so asthma, upon the other hand, is chronic bronchial and bronchial spasm, and we know that already. Okay, so these three conditions actually forms part into this what we call as your chronic obstructive pulmonary disease. So what are the possible assessments na makikita natin dito? First, we have your barrel chest. So basically, this is the increase in your what we call as your anterior posterior diameter of your lungs. So basically or literally parang naging barrel, okay, yung size po ng lung or thoracic attribute po ng ating pasyente. There's also breathing difficulty. So our patient might be using the accessory muscles at this time. Congestion, abnormal breath sounds, acidosis. Why? Because our patient here is actually having breathing difficulty. He's retaining more and more carbon dioxide here. So what does it happen? Remember that your carbon dioxide is an acid. So acidosis occurs here. Hypoxia is also possible. Okay? So how do we treat? Big word, low level oxygen. So we don't give actually high flow oxygen. We only give low level oxygen. Why is that? So now when it comes to COPD, the breathing stimuli or breathing stimulus for your patient is actually different. For us normal people, our breathing stimulus is actually carbon dioxide. It's because of the presence of carbon dioxide in our body that we need oxygen. Upon the other hand, for your COPD patients, their breathing stimulus is reversed. Their breathing stimulus is actually oxygen, because it's for a very long time they were already like their body been used to having a very low oxygen. Okay, so we manage them through low level oxygen. That's why kapag pumasok po ang pasyente natin na known asthmatic sa ating pong emergency room, what do we have there is that usually kapatid, low level oxygen, so low level din po ang kanilang oxygen saturation. Okay, so we also give them bronchodilators. We do your chest physiotherapy, yan, hydration, pursed lip breathing, and also small frequent diet. Okay, again, let's talk about your breathing stimuli. For normal people like us, it's actually carbon dioxide. It's the reason why we're breathing. It's the reason why we need oxygen. It's because of the presence of carbon dioxide in our body. While COPD, their breathing stimuli is actual oxygen, and their body has been used to a lot of carbon dioxide in their body. Okay, so that's your breathing stimuli. Another case is your pneumonia. So when we say pneumonia, what you need to do here is where the problem in your pneumonia really is located. So pneumonia is actually the inflammation of the lungs, mainly involving the alveoli, usually caused by your microorganism. Okay, it could also be caused by other causes other than microorganisms. Say, for example, near drowning, aspiration, so it can cause your pneumonia. So here, remember when we introduced this presentation, this topic, we've discussed that it is in your alveoli where the gas change occurs. So when the alveoli is damaged, there is no there is no very good exchange of gases. So alveoli here becomes filled with fluid and pus, and that's a big problem. Okay? So we need to remember this one. Okay. So what are the causes of your pneumonia? So it can be bacterial, it can be viral, it can actually be fungal, and it can be chemical irritation or big word aspiration. So always monitor your patient for risk of aspiration. Okay? So that's it. How do you diagnose your pneumonia? Of course, we use X-ray, and in your X-ray, there's this big word, patchy infiltrates, kapatid. So we need to watch out for these patchy infiltrates because it can tell us actually that we have a pneumonia. How about sputum culture? Why do we need sputum culture? That is already to identify if it's bacterial, and if it's bacterial, what type of bacteria is there, and that's it. We can know how to manage our patient. Okay, so big word for your aspiration pneumonia, we don't easily jump off to your antibiotics because it's in your bacterial cause wherein we use your antibiotics for your pneumonia. Okay, so remember that one. So what can we assess on a patient with pneumonia? High fever, cough, tachypnea, crackles. Why crackles? It's because of presence of secretions. Chest pain, increased work of breathing. So these are the assessments that we can see in your patients suffering from pneumonia. Okay, so here let's discuss about the treatment. So of course, maintain patent airway. Oxygenation is also important. Chest physiotherapy, that is to loosen and to excrete your secretions. Analgesia. So analgesia here can be used by paracetamol, at the same time antipyretics, and also we use antibiotics if bacterial cause ang ating pong pneumonia. So remember these things here. Okay, another condition, kapatid, is your acute respiratory distress syndrome. So when we say acute respiratory distress syndrome, this is your ARDS. So this is an acute condition characterized by acute hypoxemia. So dito po, kapatid, it's where there's too much fluid collection in the lungs. Okay? Hence, nagkakaroon po tayo ng oxygen deprivation. That's what we call as your ARDS. Okay? And when your ARDS happens, this can be a complication of your pneumonia. This can be a complication of trauma, say for example, near drowning. So, dito, kapatid, it's where your lung is actually infiltrated, which should be infiltrated by fluid, by pus. So, that's a problem here. Okay? So, what are the causes? It can be sepsis, it can be trauma, it can be burns, it can be pneumonia or overdose of drugs, and of course, near drowning. So what happens in the near drowning? You wash up your normal surfactant in your alveoli. Hence, you will also be having a lot of fluid within your alveoli, and that's infiltrating to your alveoli. Hence, there will be problem with your oxygenation. Okay? So, assessment. In the chest X-ray, if we have patchy infiltrates in your pneumonia, here we have your diffused bilateral infiltrates. So diffused bilateral infiltrates. If it goes out in the questions, if it goes out in the board examination, you immediately answer ARDS. Okay? And also your hypoxemia low may occur. So there's low O2 saturation here. Okay. So treatment. Of course, because it's ARDS, it's acute respiratory distress syndrome. So, intubation and mechanical ventilation. How do you position your patient? Prone. Okay? So, that is to prevent too much pressure in your respiratory system, too much pressure in the lungs. Okay, so um, prone will be the best position, and also we must prevent infection here. So infection that can be caused by your intubation and mechanical ventilation, and we call that as your barotrauma. So trauma caused by too much pressure, like your mech vent, because your mechanical ventilator gives you so much pressure. So we must avoid what we call as your barotrauma. Okay, so another condition, kapatid, is your pneumothorax. Pneumothorax is actually the presence of air or fluid in the pleural space of the lungs. Now this one is in the pleural space, not anymore in the alveoli. So we call this one as your pneumothorax. So here we can observe here, just like what we had earlier in your CTT. So if this is filled with fluids, your lungs will be pressed down. Okay? So it will be pressed down because there's too much pressure here, causing your lung collapse. So we call it atelectasis. Okay, so what are the causes of your pneumothorax? It can be infection, trauma, procedures, or your post-operation surgery. So those are the basic causes of your pneumothorax. So what can we assess? Shortness of breath, chest pain, desaturation, hypotension, tachycardia, and big word in the board examination, we have this tracheal deviation, just like here in your x-ray. So it means that the tracheal deviation is actually an indication that there is a problem with the, like this one, okay, there's already a problem with the size of either side of the lungs, that's wherein we have here like fluid or air that's pushing it to the other side. So we call that as your tracheal deviation. Okay, so we call that as your tracheal deviation. So what are your treatment? Chest tube therapy is the treatment. We've known that. We've discussed earlier about your CTT. And also avoid complication because of air leak, and we call that tension pneumothorax. Okay, remember that one. Another case also, kapatid, is your pulmonary embolism. So when we say pulmonary embolism, this is a life-threatening condition. It's where there's a presence of clots in the lungs. It can be caused by your embolism. Okay, embolism from the different parts of the body enters into the right atrium of the heart, down to your right ventricle, going to your pulmonary artery. Okay, and of course going into your uh, respiratory system, and this can actually lead to heart failure. Remember that one. Okay, so what is the assessment? Again, kapatid, big word in the board exam. If your patient has this restlessness, anxiety, wherein the patient cannot really feels that he cannot anymore breathe, okay, parang nalulunod si pasyente, that's anxiety, that's restlessness, that's an indication of pulmonary embolism. Dyspnea is also seen, chest pain, hypoxemia, RALS, diaphoresis, and also hemoptysis. Okay, that's also possible. How do you manage your patient? We give your patient oxygen. Yan, that's the priority here. How do you position your patient? We position your high Fowler's position. This is to allow the expansion of the lungs. And we also give your anticoagulants like apixaban and thrombolytics like your altiplase. Okay. So before ending up our lecture, let's have first a practice question here for PNLE. A patient was admitted at respiratory unit due to aspiration pneumonia. Which of the following management should not be included? A. Paracetamol for fever. Letter B. Oxygen support. Letter C. Chest physiotherapy. Letter D. Antibiotics. What do you think is the answer? I know you got it right. The best answer here is letter D. Okay. So the question is actually which of the following management should not be included? So letter D, antibiotics should not be included. Why? Because your antibiotics are primarily given to pneumonia with aspiration as a cause. Antibiotics are given for bacterial type of pneumonia. I've said it a while ago. Maintenance of patent airway is the priority in this case. So letter B, A, B, and C are correct. So antipyretics like paracetamol is needed for fever in pneumonia. Oxygen support is most important management in this case. So the patient's oxygen may have been diminished. Yan, due to alveolar problem. And also chest physiotherapy is needed to facilitate drainage of excess mucus and secretion. So the best answer is letter D. I hope you got it right there. Okay? So thank you so much guys for being with me today. So I'd like to invite you to subscribe to my YouTube channel and of course follow also us in our social media lines. We have also in Facebook and also in TikTok. Maraming salamat po and have a good day.